Okay, hi guys. So I could not finish this last night, so I'm doing it today. Hopefully it'll just be super quick. I just wanted to run through the questions and show you guys kind of what to look for in questions. Just a heads up, my dog is on my bed, little angel, but he's incapable of not barking when someone walks by my room. So just a heads up. I'll try to mute it when he starts barking, but okay. So here's obviously a meme. And if you guys watched the inguinal hernia part, hopefully this makes sense. And you're like, oh, I love it. But if this is the inguinal canal, direct hernias, remember they go directly through the triangle, not through the canal, just like Mermaid Man here. All right. So first question, pause it, give yourself enough time. I'm just going to start talking. So this person has arrived at the emergency room, 33 weeks gestation, the 33 weeks gestation. Okay, elevated beta HCG. You guys will kind of go into this a little bit more with repro, what this means. You don't really need it for right now. Like, what does it mean to have elevated beta HCG on triple screen and increased nuchal translucency? This does help if it would help you with the diagnosis if you knew what this meant, but you don't need it. So within 2 hours, so 2 hours, the baby develops bilious vomiting. So remember, like I said, it's really important to remember bilious versus non-bilious and then timeline because, like for example, like if you're between for these two, if you're between, because we know it's bilious vomiting. So if you're between like two, the time, what is he doing? Oh my God. If you're between two, that can help you the timeline. Okay. So this answer is duodenal stenosis. So bilious vomiting, we are in the duodenum, you would see that, but also with this happens fairly quickly, where something like pyloric stenosis would happen after like 2 weeks. And then a TEF is non-bilious vomiting. And then they also show you an abdominal x-ray and you see the double bubble sign, so that also helps you with duodenal stenosis. So here's your duodenum and then here's the stomach. Okay. And then here's the answers. You can kind of go through these on your own. Okay, so next one, pause it. Pause it if you need it. So this one is 1 week now after delivery. We have a male newborn. Remember, it kind of helps you a little bit with some of the pathologies for male. Multiple episodes of bilious vomiting and abdominal distension. Blah, 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 going through it, blah, 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 blah. Okay, digital rectal exam shows increased anal sphincter tone and an empty rectal vault. The remainder of the examination shows no abnormalities. Here's an x-ray. So this to me, remember x-ray, left, right, anatomy, brain. This looks very, very large. So automatically I'm like, okay, empty rectal vault. There's no stool on the doctor's finger when he does that test. So I'm kind of thinking Hirschsprung's, right? So you're kind of thinking Hirschsprung's. This is a very board style question because usually for your exams, for example, they would say, what is this diagnosis? But for boards, it's like, okay, you know it's that. Now here's this other question about whatever the pathology is. So now it's kind of like, all right, which of the following is the underlying cause? So it's like kind of like what causes Hirschsprung's basically. And Hirschsprung's, if you guys remember, this would be defective migration of the neural crest cells. Remember, the neural crest cells don't migrate, and then you don't have those, the neural, like the Meissner's plexus and Auerbach's plexus where they should be. And this just reminded me, I wanted to mention for this last one, the increased beta HCG on triple screen and increased nuchal translucency is usually like a sign of Down syndrome. And remember, Down syndrome is associated with duodenal stenosis. So I think they do mention it. Actually, I don't know if they mention it here. Yeah. So they mention it is Down syndrome. So it was like you didn't need to know it, but it does help you. It's the same with kind of the same thing with Hirschsprung's can also be associated with Down syndrome, kind of in the same idea. So they could have put something like that in here as well. Okay. And then some of the other ones we did talk about. So for example, like invagination of bowel loop into adjacent bowel loop, that's telescoping. So this would be like intussusception and so forth. Okay, but that's all in here. You guys can go through these on your own. Okay. Next one. So you can pause it, but I'm going to go right through it. So we have a 3-week-old boy, non-bilious vomiting. only gained 8 ounces since birth. So clearly, like, either he's not getting food or he's not getting the nutrition from the food. So parents report he's a fussy baby who does not like to feed. When he does eat, he vomits several hours later. So clearly there's a blockage. There's some sort of blockage, but it's occurring before or right at where the duodenum, like where the second part of the duodenum is, where the ampulla of Vater is. So abdominal imaging shows tissue surrounding the second portion of the duodenum. So they're basically telling you what this is. So there is tissue surrounding the second portion of the duodenum. I'm kind of thinking this is the annular pancreas, right? Because we have the duodenum, and then if the ventral bud over here, if it doesn't go behind like it should, it goes in front. It can just kind of like squeeze. It can kind of like squeeze right at that second part where the ampulla of Vater is, and bile won't be able to come into that. That's why I get your non-bilious vomiting. So then, kind of the same thing, what's the underlying condition of annular pancreas? And hopefully you're like, okay, that's basically failure of pancreatic ventral bud rotation. Because remember, the ventral bud is supposed to rotate behind, but sometimes it can rotate in front, and that's when you get this pathology state. Okay? And then, for example, the failed fusion, this was the other one we talked about, letter D. This was the pancreas divisum. But again, you wouldn't see that tissue on the second part of the duodenum. You might not even see any symptoms at all. Okay. All right, so this is for my people that watched the inguinal hernia part. So if you didn't, skip it. I will just make sure you come back and watch it then when you do inguinal hernias in repro, because this is a good question. So we have a 20-year-old man, and remember I said with these inguinal hernias, like 20-year-old man, I'm not really thinking like weakening of the transversalis fascia, which totally can happen. But if it's like a young, healthy man, I'm already kind of thinking indirect, which don't like automatically pick it, but just kind of like be like, okay, this might be like, think of my brother who plays football, right? He had an indirect inguinal, like he was a healthy guy. He was he was like 19 or 20 when it happened. That's usually who it is because they're weightlifting, they're healthy, they're doing something that kind of moves the bowels around. Okay, so he's a 6-month history of a painless mass in his left groin that has been gradually increasing in size. You guys will kind of go into this a little bit second year, but whenever you see a painless mass, it's actually usually indicative of cancer. Like when they mention that in a vignette, they want you to think it's cancer versus if you have like, if you're sick, like especially with lymph nodes, it's like if you're sick and it's like you have mono or like you have some sort of illness where your lymph nodes get swollen, usually that's painful because of inflammation and redness and swelling, and we'll go into it with immuno. But just wanted to point that out. Painless mass, it's usually like, oh, this might be cancer kind of thing, which we know it's not cancer. This is, I literally told you it's going to be an inguinal hernia question. So this is an inguinal hernia. And it's been gradually increasing in size, which you might not think anything of, but it does also kind of help you with the diagnosis. So there's an oval, non-tender left inguinal mass and a fluctuant, so it kind of moves around, painless left scrotal swelling that increases in size with coughing. All of this can help you. So which of the following is most likely the cause of these symptoms? So probably an indirect inguinal hernia, right? Because it doesn't really give you much to help you diagnose it. It doesn't tell you about those inferior epigastric vessels. It doesn't tell you about if it's within that inguinal canal. It doesn't give you that. So you're kind of going off of like, okay, this is probably indirect inguinal hernia, especially because a lot of the times indirect inguinal hernias are associated with hydrocele. Remember hydrocele? And that's kind of what they're going with here. If you have that, I don't want to give the answer away. Actually, we'll just do the answer. So this is going to be failure of the processus vaginalis to close. So remember, these indirect inguinal hernias, the underlying cause of it is because the processus vaginalis does not close. So you have the peritoneal cavity, which should not be attached to the scrotum, but it is, and then you can get basically swelling of where the testicles are, like this area next to the testicles, and that's called a hydrocele. And them basically saying it's gradually increasing in size, the peritoneal fluid just keeps leaking in there over time. Like it just keeps getting there, it's getting bigger and bigger and bigger. But then they also tell you it increases in size with coughing. So something that increases intraperitoneal pressure. So you have the patient cough, it's gonna put more fluid down into the scrotum. You have the patient do Valsalva. So sometimes they won't say like patient performs Valsalva. They'll say like when the patient blows on an empty syringe or when the patient blows on a pen. That's them trying to say it's Valsalva. They could say laughing, sneezing, anything that's gonna like when you go haha and then you laugh, you like your intraperitoneal cavity, you feel like your abs contract. That's kind of like increasing intraperitoneal pressure. So that's just adding to it. So that's kind of what this is, and this is exactly what a hydrocele is associated with it. Okay. All right. Okay, back to my GI people. So for this one, we have a 2-week-old boy. Okay, so not newborn. It's a boy brought to the ER, continuous bilious vomiting. So his mother says he was feeding normally, so normally up until 2 days ago. So since then, he has not been able to keep food down due to vomiting of bilious material. I want to stop you guys right here because basically, like almost right away, if you weren't like, if you didn't realize bilious versus non-bilious, if you didn't kind of like, if I didn't tell you like that's going to be a very big like make or break kind of thing with these questions, you would be like, this sounds like pyloric stenosis, right? Because like you're like 2 weeks, like he was fine until 2 weeks, it's a male, like you're like, wow, this is pyloric stenosis. But remember, pyloric stenosis is non-bilious vomiting because the stenosis is before the ampulla of Vater. It's way up in the stomach still. So this is not pyloric stenosis, okay? So again, this is kind of what I'm saying, like really look at timing and bilious, non-bilious. It'll really help you with your diagnosis. All right, so temperature, okay, blah, blah, blah. His abdomen is tender and slightly distended. Abdominal x-ray is normal. So which of the following is the most likely diagnosis? So this is a tricky question, but how like you can kind of approach something like this is you know that there is some sort of blockage or there's something somewhere because he is vomiting and he has low blood pressure. He can't keep any food down. So they even tell you that the abdominal x-ray is normal. But if you kind of go through, so we know it's not pyloric stenosis because that's non-bilious vomiting. Kind of the same thing with, oh, it's not even on here. I thought it was going to be the TEF, the transesophageal fistula, but that's not on here. That's also non-bilious vomiting. So it is bilious. So we know we have to be after the ampulla of Vater. So something like biliary atresia, like, yeah, it could be like, it could be some sort of like bile, but biliary atresia tells me like the bile duct can't empty into the, you know what I mean? It's basically saying like the bile duct has atresia, it just stops short basically. So that would be non-bilious. GERD, why would you see bilious vomiting if you have GERD? Like if you have just reflux, like that's not, again, not what it's talking about. So we're between intestinal atresia and malrotation with volvulus. Intestinal atresia would be something like duodenal atresia, jejunal atresia, ileal atresia, something like that. Usually, remember with those, you see the symptoms immediately because again, you don't have like part of your duodenum, you don't have part of your jejunum, it's not there. It's not even like it's like there and then it's like, oh, here I grew. Like it's just not there. So you would see it happen a lot faster. So this one is actually going to be malrotation with volvulus. And remember I said yesterday, well, in the other part, that a lot of the times the abdominal x-ray can look normal. So don't get got on that because it can look normal and it's totally fine. It just, for whatever reason, it just doesn't get picked up on x-ray. But the volvulus is now, it's almost like the patient probably had midgut volvulus, or sorry, midgut malrotation, which was fine up until now it probably turned into like volvulus, which is that true obstruction, and now they're starting to throw up. So this is a little tricky question, but I liked all the teaching points of this. So like one of the key points right here is in atresia, there's no lumen for intestinal flow. So vomiting is going to happen shortly after the baby first begins to feed. So it's like the fact that the baby was feeding normally during the first weeks of life makes this like very unlikely. And then down here, this is just basically Dr. Ryan from Boards and Beyond saying like, no bilious versus non-bilious vomiting. Like it's gonna help you. So vomiting can broadly be divided into bilious, non-bilious. Non-bilious vomit is slightly yellow because it has bile, right? This type of vomiting is often seen in viral gastroenteritis. Bilious vomiting is green from the large amounts of bile. Oh, did I say that wrong? So non-bilious vomiting is yellow. There's like not too much bile in it. There could be a little bit, but not much. Bilious vomiting is like it's after the ampulla of Vater. So this implies a lack of bile flow due to obstruction from the intestine. So anything beyond the ampulla of Vater is going to basically be your bilious vomiting. All right, last question. This is another inguinal an inguinal hernia question. So if you did not watch those, you're done. Great job. Probably answered those all correctly. But so for this one, we have a 79-year-old man. So again, if I read this and I kind of am seeing it's a hernia question, you know I'm already being like, all right, 79-year-old man. I'm already thinking direct, because that's like the age, that's kind of like the patient population for direct. It's like an older guy who probably lifted something heavy. So he reports he's had groin swelling that worsens with standing, coughing, straining. This is kind of like the same thing. You're increasing intraperitoneal pressure. It's just kind of like making it feel worse. Even if it's direct, like I know you're not seeing the swelling that can get bigger and like, get even more swollen with like anything that increases intraperitoneal pressure. But imagine your bowel not being where it should be. Like increasing intraperitoneal pressure is just going to make it feel worse. Just any type of inguinal hernia. Okay, so examination shows a non-reducible bulging mass of the left groin that is severely tender to palpation. The overlying skin is erythematous. There's protrusion of abdominal contents through a defect medial to the inferior epigastric vessel. So they are telling you what this is. You don't even need to do all that legwork we just did. So which of the following is the most likely site of protrusion? So they basically are asking, all right, if we're medial to the inferior epigastrics, remember MDs don't lie. MDs, medial to these vessels, that's going to be a direct inguinal hernia. And you're like, well, that fits with this patient population. So now it's like, which of the following is the site of protrusion? We know it's through Hasselbalch's triangle. We know it's through that inguinal triangle, which is this answer. Remember that they try to get you with direct because they want you to think it's directly through the inguinal canal, or something like, the deep inguinal ring. Like they want you to pick that because it's like people think of that. Like, I don't know why. It just comes up so much. Like people think of direct inguinal hernias go directly through the inguinal canal, and that is not true. It goes through the inguinal triangle. So just remember that meme with Mermaid Man. He's not going through the door, which would be like the inguinal canal. He's next to the door. He's in Hasselbalch's triangle, this inguinal triangle. Okay, so that's kind of what it says here. And then just remember to the transversalis fascia, this is always going to be the first layer crossed by any hernia. That's just like another common anatomy question that they can ask. Okay, but like this question too, a lot of people, more so than shouldn't, picked deep inguinal ring because that's for the indirects. Okay, I know it's kind of weird, but you have to think of direct as directly through Hasselbalch's triangle. All right, and then here's just Amboss's picture of all those layers, because remember, it goes from, these guys are from the stomach, and then remember, they kind of, they didn't do that here. Well, they go, and then it associates with what's around the scrotal swelling. Okay, that's why I wanted to show this. I like this picture too because it showed there is an obliterated processus vaginalis here. That's just what should be. And a lot of the times with indirects, there's no obliteration of the processus vaginalis, but you can't really see it because the intestines are through here. And then I'm trying to think other stuff they can ask too. Directs go through the inguinal triangle up here, which is medial to the inferior epigastrics. But remember, they can also go through the superficial inguinal ring. So even this question, that was it. Even this question, notice that superficial inguinal ring was not an answer choice because that could have also been correct because the directs go through Hasselbalch's, but then they also go through the superficial inguinal ring. Whereas indirects go through both deep, is that the one? Deep, yes, deep inguinal ring as well as your superficial inguinal ring, which is I think it's just down here. Okay. All right. That's it. I got to go to lab. But if you guys have any questions about those, just let me know because I know we're doing this live. And hopefully we're not doing this live. We're not, actually the opposite. But if you guys, and then I'll hopefully see you guys next week for a live session. We'll do some physio. Okay. Bye, guys.